Warm welcome to all the participant, eminent expert on this webinar, which is on the World COPD Day. We celebrated World COPD Day on every third Wednesday of November every year. And this year we have a theme of Know Your Lung Function. So I welcome to all on this exclusive webinar for occasion of World COPD Day. So before initiating the webinar from the expert, I would like to share a few things which is already uh, implemented in the national program. So under the umbrella of National Program for Prevention and Control of Non-Communicable Disease, we have the umbrella of various entities like cardiovascular disease, diabetes, chronic kidney disease, CRDs, chronic respiratory disease, including COPD and asthma, non-alcoholic fatty liver disease, the common cancer, oral breast and cervical, the stroke, STEMI. However, no one is compared to other disease, but it is fortunate that we have done tremendous job in the cardiovascular disease and screening of cancer. However, we are still lacking on the CRD part pan India. So this webinar will help us to initiate the thing in the community where we are implementing the screening, suspecting, confirmation, and patient putting on the treatment. We have the various risk factors for these entities like alcohol abuse, physical inactivity, air pollution, smoking, diet. So mostly recently, what we have observed that air pollution, smoking, and other environmental factor also contributing the major contribution to the chronic respiratory diseases. In India, apart from cardiovascular disease, we have estimated burden of 3.8 crore cases of COPD, contributing to almost 18% of global burden of COPD, which is second rank in the world. Since we have the Sustainable Development Goal to be achieved by 2030, reduction of the premature
Okay, sir,
mortality.
are you changing your slides? Because your first slide only is being shown.
Sir, could you please put it on slideshow mode
Yeah.
from the beginning slide?
Now it is visible.
No, not yet, sir. Sir, yeah, please
Is
click on this icon. If it is not accessible, then on the left side up top of the corner, there is slideshow option on the top ribbon, sir.
Is it visible?
Yeah, fine, sir, fine.
Yeah. So we were discussing about the risk factor for NCDs where the air pollution and smoking and other environmental factor are contributing for the chronic respiratory disease in the community, COPD and asthma and other diseases. So we will have the second highest burden of the COPD among global, contributing almost 18% of burden in the respect to COPD diseases. And we have the target of 3.4 by which we need to reduce the 1/3 premature mortality from the non-communicable disease through prevention and treatment and promotion, mental health and well-being by 2030. So contributing from the various communities, field level, from Ayushman Arogya Mandir, PSC, If we have the services available at the periphery, this goal can be achieved in the shortest time. With respect to evolution of our national program on NCDs, the program was initiated in 2008 as a pilot phase. However, the expansion was done in 2010, and various component initially was added like hypertension, diabetes, and three common cancer. But later on in 2021, we have included few more component, including the chronic respiratory disease, COPD, asthma, non-alcoholic fatty liver disease, etc. Recently, the changes was done in this program. First of all, I really congratulate to all the expert and the healthcare provider that we could achieve the 7,000 NCD clinic across the country. And in 2023, we have launched our operational guidelines for this program. And this year, we are now piloting the various point of care devices so that the screening of any services can be happened in the easiest way by using the artificial intelligence. So under the program focuses on the health promotion awareness. We have population-based screening of 30 years and above, including COPD and asthma. The data and recording and reporting are done through our National NCD portal. We have care continuum model. Moreover, under the leadership of Honorable Prime Minister, we have our multi-sectoral approach where the whole of government and whole of society can contribute for our common goal. Other ministries also contributing through this and for this NCD, Eat Right India, Fit India movement. These are the various facilities which are placed at the district hospital, CSC level, or below there. We have released our 2021 guideline, technical guideline, where the COPD services are how we should place the COPD services in the PSC, CSC, or district hospital. The use of spirometry for the diagnostic purpose as the CSC or district hospital. Around 400 districts have now providing the COPD services pan-India, and few states already upgraded their facilities uh, uh, across their districts. So I request to all the state officers that they need to have look into their services, which is not lacking in their district or below district level, so that we can achieve all it to entire state uniformly. So with this overview, I'll end here, and I'll would like to introduce that uh, I would like to introduce Dr. Sanjeev Nair, who is professor and head of Department of Pulmonology, Government Medical College, Thrissur, and he is also holding the chairmanship of Zonal Task Force of Medical College in NTEP South Zone 2. He is also heading the President Academy of Pulmonary and Critical Medicine. And sir are eminent expert in the various committee, heading the chair of many, including the Central TB Division, and holding the holding the TB clinic as well in the Kerala. So I welcome to Dr. Sanjeev Nair sir, and we have technical session how this COPD, asthma, the CRT services should be happen in place in the community. I welcome sir again. Over to you, sir. Before initiate this presentation, I request all the participants may write their question and answer so that at the end of the session, our technical expert, Dr. Sanjeev Nair, can answer of your questions, please. Yep. Thank you, sir. Over to you, sir.
Thank you, Dr. Sunny. Thank you to the entire program team, NCD team, for the invitation to interact with all of you. Uh, Let me start by sharing my slides. Are my slides visible
Yes, sir.
in slideshow mode? So, good afternoon. My mandate for today is to discuss the prevention and control of chronic obstructive pulmonary disease, or COPD as we call it. And been given 20 minutes to discuss a fairly large topic. So I'll focus on certain things and maybe rush through a bit to finish in 20 minutes. You can always come back to me with questions on any specific areas, which I might have not dwelt with in detail. Yeah. So the plan for the day is for the 20 minutes, I'll be discussing in brief what COPD is, slightly couple of slides to discuss COPD versus asthma, how to differentiate, because that is very important. And also in terms of what causes COPD and how to prevent it, and also some of the management options. So COPD, the international definition, the current definition talks of COPD in a very nice way. The definition, I am not generally a person who remembers definitions, but this definition is very useful because it helps to understand the disease per se. In fact, one slide can actually cover the entire talk that I'm going to give. So it speaks on certain things, that it is a heterogeneous lung condition. So there is various levels of involvement, various ways of involvement. The major issue here is chronic respiratory symptoms. The symptoms are also there in the definition. In fact, dyspnea, coughs, sputum production, and or exacerbations. Now, why are these symptoms there? Because of abnormalities of either the airways, or the airway abnormality have been defined there as bronchitis or bronchiolitis, and or the alveoli. So it can be either airway or alveoli or both. So the alveolar involvement is called as emphysema. And this causes persistent, often progressive airflow obstruction. So this is what is COPD. So we'll look at it a bit more closely. Why are we discussing COPD? Why did Dr. Sunny and all the seniors actually include COPD in the NCD program at a later date? Because it is a leading cause of mortality and morbidity in India. We'll just look at it briefly. It's a poorly recognized disease. So the reality in India is that despite COPD being such an important disease, often people don't know much about COPD, and it is underdiagnosed as well. And the quality of treatment that is provided to COPD patients in India, there are multiple studies on that. It often is suboptimal, and patients are not well managed. In fact, a few years back, maybe about 5 years back, one of the COPD days like this, I had been invited to one of the major primary health centers in Kerala, and the audience for me there were all the field staff there, the JHI, JMHNs, and health supervisors, and everybody. About 23 people were sitting there. And in fact, I asked them what COPD was, and in fact, nobody there actually knew what COPD was. They all had heard of COPD, they all had their concept about COPD, but that was very different from what COPD actually is. So, that is something that we need to understand. So, we ourselves have to understand COPD before we actually take care of the periphery. Now, why is COPD important? Like I said, so worldwide, COPD was even in 1990 one of the in the top 5 causes of death, which now has gone to the top 3 causes of death in the world. But whereas in India, in fact, it was not in the top 5 at that time in 1990, but today it's the second leading cause of death in India. So it has been going up. The proportion of deaths due to ischemic heart disease, which is the first cause, and COPD, which is the second cause, have been on the increase, and the numbers have also been increasing. So this is a important disease, and it's unfortunate that the second leading cause of death in India, the disease, many of our people, general public, are not even aware of this disease. Of course, unfortunately, we don't even have an Indian name for COPD, so that people don't even have a name to recognize their disease. We should understand that the ICMR and the GBD have brought up a lot of data, and you can actually go to this website called GBD India Compare, and in fact access good quality data, which will help you to make presentations if you're doing it in your local area. State-wise data is also available. Now, how do we diagnose this important disease, COPD? So there are 3 important things you have to look for. First, your patient should have symptoms, and then the patient should have the right risk factors. And in a patient with symptoms and risk factors, you have to do an objective test, measurement of lung function, which is spirometry. And based on the spirometry, in the spirometry, you need a specific measurement, a post bronchodilator, FEV1 by FEVC less than 70% to make a diagnosis of COPD. So these three things come together, and all of them should be there to make a diagnosis. Now, internationally, the latest guidelines, this year's guideline actually talks of a few more symptoms. So the symptoms are clearly defined. The major symptom is breathlessness, difficulty in breathing, or dyspnea, which is generally progressive, worsens with exercise, and is persistent. So these are the characteristics of the breathlessness that you can have in COPD. Recurrent wheeze, which we generally consider as a symptom of asthma, has now been listed along with COPD as well in the international guidelines. Chronic cough is a very important symptom of COPD. And also, it may be with sputum production or without sputum production. So, a person who has cough with sputum production for 3 months for 2 consecutive years is said to have chronic bronchitis. Anyway, the other important symptom that we talk of is recurrent lower respiratory tract infections. So, when your patient has any of these symptoms and any of the risk factors which are listed there, the international guidelines always list tobacco as the most important risk factor. But now they have started recognizing other risk factors like smoke from, indoor air pollution, like by cooking, occupational dust, and various host factors. So if you look at it carefully, again, internationally, in many countries in the world, COPD is a disease of smokers. And then, of course, industrial pollution, workplace pollution, passive smoking, and then only a small chunk by indoor or outdoor pollution. In aging population and genetic susceptibility, this can cause. So smoking and passive smoking would be the major risk factors in Western countries. But in our part of the world, the major risk factors are different. So there are studies which are published in the Lancet which showed that in India, maybe 70% of the COPD, almost 70%, could be due to factors other than smoking. So particularly indoor air pollution, because in India, COPD is equally common in women as in men, which is surprising because smoking is very less in women in India. But then COPD is common in women because of this problem of indoor air pollution. Now, the international community has also recognized this. And if you look at COPD, now they classify it into various forms of COPD. COPD-G is genetic, where you have enzyme deficiency like alpha-1 antitrypsin deficiency, or COPD-B, which is developmental, where child birth abnormalities will be there. Environmental COPD includes COPD-C, which is due to smoking. In India, BD smoking is a major thing, whereas in Western countries, they don't talk of cigarette smoking. And then COPD-P, which is due to pollution, outdoor, indoor pollution, and also occupational. Then you have COPD-I, which is due to infection. So tuberculosis is a major infection. So if you know, in India, 25 lakh people get treated for tuberculosis every year. So when the 20 lakh cured people, out of that, even 28% can develop COPD, which actually means that about 5-6 lakhs of COPD may get added every year to our COPD population out of our cured TB population. So that is again a major risk factor for India, which will not be there in many other countries in the world. And then there are other causes of COPD as well. So one of the headings given to me was prevention of COPD. So before going on to diagnosis and management per se, one of the issues that we have to look at is as a public health problem, we should look at prevention. Now, prevention in Western countries and even in our country, 40% of our COPD are due to smoking. So the most important preventive measure will be smoking cessation. So, the 5 A's of smoking. Time doesn't allow me to go into detail. This needs a lot of deliberation. But then you can have pharmacological and non-pharmacological support for smoking cessation. And our division, NCD division, also has a helpline and other supportive tools which actually helps your patient. So the main thing is you have to remember that your patient needs smoking cessation and link them to that. The other one is, it may not just be the smoker. In many of our households, you will see that people do smoke inside their home. So that culture is there. So you have to protect the family members also from passive smoking. Post-TB care, which the TB program of India does emphasize on, that patients should be followed up for 2 years after cure, but that doesn't happen very well in India. So if we can do that well and provide them good care, then we will identify COPD, also take care of TB. So linkages between the TB program and the COPD program, which is one of the next coming agendas for this series of CMEs. So that will be discussed later, maybe next month. Then repeated infections in childhood can be managed properly, vaccination in children and all can also prevent COPD in the long run when these people become older. Major one is, of course, air pollution, indoor and outdoor. Dr. Sunny and I were discussing the issue of outdoor air pollution, but then that is a bit difficult beyond the scope of healthcare workers here. But definitely, when it comes to indoor air pollution, we should actually do our bit about it, link them to the schemes which actually help them. So, smoking cessation, this is a very popular graph that we all use. So, smokers have a decline in lung function, which is much steeper than a non smoker. But whatever the point at which we stop smoking, and even after the damage has occurred, even after they have developed symptoms, so whatever the point they stop smoking, still you can prevent the progression of lung function. This is much better than the medicine, what medicines can do for the patient. So this is a very important measure, and we should never forget that in our patients. Now, one of the successes of India, which came out in one of the publications which I have also, I am also a member in this publication, was looking at fuel switching. So if you look at it, if you look at India here in the middle, you can see that, in the earlier period, India had a high level of biomass fuel being used for cooking in our villages and all. Whereas that moved much less uh, during this period of the study. Same in China, India, but the difference that happened in India is much more than other countries. You should also compare to our neighboring countries. If you look at Bangladesh and Pakistan, this difference is not there at all. So, our country has been extremely successful. Our government's program of providing free cooking gas. So, you can link your patients with COPD and respiratory symptoms to these schemes and help them to get a move to a cleaner fluids, which is possible in our country. Many countries, it may not be possible. And even inside our country, region to region, there is a lot of difference. If you see my place, Trivandrum, again, you can see there is still scope for improvement. So Chennai is doing well, better than many of the other cities. But then even in the cities which are doing well, there are still a substantial percentage of population who may need cleaner fluid. We'll come back to our diagnosis per se. So if we come to the diagnosis, again, like I said, symptoms we already discussed, risk factors also we discussed. In such a person, we need a spirometry or a proper tool to make a diagnosis. Now, the guidelines that Dr. Sunny was mentioning earlier, I don't have time to discuss that per se, but all the guidelines, we have a similar guideline in Kerala called the Schwarz guideline. All these guidelines now talk of objective measurement to establish a diagnosis of COPD. So the major measurement required is a spirometry. So this is the Schwarz program in Kerala. And the lady standing there is our previous health minister. And the man on the extreme left is our local member of Legislative Assembly and Dr. Manu who runs the Schwarz program. So one of the successes in Kerala was that we could make our health minister herself do a spirometry. So, when you get the ministers and the local leaders and all to get involved in COPD management and spirometry, then you get more importance for that important test. You should remember this year's theme for World COPD Day is know your lung function. So, you have to measure your lung function, and reduction in lung function can lead to many diseases, including heart attack and all that. COPD is just one of those diseases. Similarly, one of the old COPD Day 5-6 years back, our team in Ernakulam actually made one of the leading actors in Malayalam cinema who also has acted in Hindi cinemas and all to do a spirometry himself. So, you have to popularize the test, which is not very commonly done these days. So, spirometry, you get various results. The major result you have to look at is FEV1 by FVC. And if the FEV1 by FVC after a bronchodilator is less than 70%, you can diagnose COPD. Now, it is important because at the end of the day, we have a huge burden of COPD in India. And the medication that when we start getting the right medication for COPD, it will never be enough for our patients. So in that context, if we give medicines to people who do not have COPD, we will be wasting essential medication. So objective measurement of COPD is very important. Then you can classify the COPD further for severity based on the another measurement called FEV1, which classifies COPD into 4 groups based on the FEV1 levels. And also you look at something called reversibility, which differentiates COPD from asthma. Time doesn't permit me to go into detail of this, but then that is essential test. Now, the last bit of it is the management of COPD. In the management of COPD, the most important thing, the initial step should be to differentiate between asthma and COPD. As you saw, COPD is the second leading cause of death in India. Asthma is the 14th leading cause of death in India. Now, as a respiratory physician, I would believe that COPD deaths, they are older patients, they have an irreversible lung condition. So COPD deaths may not be preventable to a large extent, but asthma, I believe that nobody should die of asthma because it's an eminently very curable disease. With good treatment, you can actually prevent death, and that still remaining 14th leading cause of death in India is a shame for all of us. So after that, you start managing COPD with pharmacological management and non-pharmacological. I just discussed this in brief. So discussing, on asthma versus COPD, this could be a syndromic diagnosis as well to differentiate. Asthma, generally, the age of onset is lower. COPD age of onset is higher. Atopy, that is rhinitis, allergic rhinitis, skin allergy, and all is associated with asthma, not generally with COPD. Symptoms in COPD are persistent, it is exertional dyspnea, persistent symptoms, progressive symptoms. Whereas in asthma, it is episodic symptoms which vary over time, and generally, even after 10, 20 years, the extent of symptoms remains same. Family history is present in asthma, but the family history, you have to take ask grandfather, grandmother, mama, mami, chacha, chachi. So you have to take the entire family history and their family history of asthma, family history of any allergy, which is usually present in asthma, not present in COPD. Risk factors, like I mentioned earlier, cigarette smoke, biomass fuel exposure, work, occupational exposure are all have to be there in COPD, may or may not be present in asthma. And finally, of course, we have to do a spirometry, which our MCD program is planning to provide at least at district hospital level and maybe even at the taluk hospital level. So that is the plan that we have, and that may be essential to make a difference. Why this differentiation is important? Because the treatment of asthma and the prognosis of asthma is different. So if it's an asthma patient, you can make them perfectly normal. If it's a COPD patient, you will reduce symptoms, you will reduce exacerbation, you will reduce mortality to an extent, but not to the extent as in asthma. And the treatment is very different. So if it is asthma, that patient has to get an inhaled corticosteroid. And if it is COPD, the patient has to get an inhaled bronchodilator, and steroid should be given only when required. So I'll not go into details of this, but this differentiation is very important for us. Now, for management of COPD, you have a circle where you start with symptoms, you do an initial assessment, start the initial management, both pharmacological and non-pharmacological. Then you review the patient, and then you look for need for other interventions and adjust the treatment. So that is how you do. So the pharmacological management per se, you do it by classifying the severity of patient based on symptoms. So generally in public health program, we use the MMRC, which is a simpler tool of measuring symptoms. MMRC 0 to 1 and more than 2, we separate into high and low symptoms. And then you look at the exacerbations, high exacerbator, low exacerbators, hospitalization, no hospitalization, and then you classify based on that. Mildest patient can benefit from any bronchodilator. The more severe they become, you may need a combination of bronchodilators. And then if they become even more severe, then they may need a triple bronchodilator like a long-acting. So the LAMA is a long-acting beta agonist, which is a bronchodilator. LAMA is a long-acting muscarinic antagonist, which is again a bronchodilator. And the inhaled corticosteroid may also be needed in a patient. So these are all the drugs that are traditionally, should be used for the treatment. So if you looked at it properly, all drugs I mentioned are inhaled medication. So when you're giving inhaled medication, there are various devices which can be used to give inhaler to our patients. And the most important thing is that your patient has to use the inhaler properly. So when the government is supplying very costly drugs to the patient, if the patient's inhaler technique is poor, which is very common. So even in patients coming to a medical college, you will see that only 20% of patients had a very good inhaler technique. Only about 55% had a satisfactory technique. 45% of them are using it very badly. So if government is providing costly medications and the patient is not using it properly, then the whole thing is a waste. So we all need to learn how to use inhalers properly and guide our patients on proper use of inhalers, which is crucial for good management of both asthma and COPD. We should also understand that COPD is a disease with multiple comorbidities. So you can have respiratory comorbidities like, lung cancer, tuberculosis, which we are going to discuss in the next meeting, cardiac comorbidities like hypertension, coronary artery disease, which are all part of our NCD program, and also other system comorbidities, which include diabetes, depression, anxiety. These are all part of our NCD program. So COPD should not be taken as a standalone program. it has to be managed with all the other NCDs being managed. You have to actively, if you get a COPD, actively search for diabetes, actively search for hypertension, and ensure that that is also managed properly. Only that will make your patient better and also increase the survival of such patients. Non-pharmacological management actually is more important than pharmacological management. I should have told that first, but it's coming later in my slide. So the most important ones are smoking cessation, pulmonary rehabilitation, which again we are going to include in our NCD program, immunization for various diseases, including influenza, COVID, pneumococcus, and all that. Diet is very important. Ideal diet for COPD patients should be given. Psychosocial support, which is part of our NCD program again, and long-term oxygen therapy or non-invasive ventilation therapy may be needed in a small proportion for COPD patients. Smoking cessation, again, I mentioned, how much ever I mentioned, very important, not just for COPD, because your COPD patient may die of coronary artery disease, may have hypertension, may have. So all the NCDs put together, smoking cessation is very important. Pulmonary rehabilitation is very important, but unfortunately, my own study in Kerala showed that it doesn't happen in field conditions. So, but we have good examples like this example from Trivandrum, one of the private hospitals, but such good gyms and everything may not be available to our government hospitals. So we have to innovate and we have to make our own local solutions. For example, the guidelines in Kerala, we wrote a chapter on yoga for pulmonary rehabilitation. We have to find our own local solutions on how we can deliver pulmonary rehabilitation. But even if that is not possible, don't forget that even a leisurely walking, we tell all our patients with diabetes to walk, we tell our patients with coronary artery disease to walk. But when it comes to COPD, generally we ourselves make the mistake that, आपको इतना, you have so much of dyspnea, आपसे तो उठा भी नहीं जा सकता. So don't sit at home, don't walk. That is the worst advice you can give to your COPD patient. Make them walk. Any physical activity is extremely good for your COPD patients. So I'll conclude by saying that COPD is a common cause of mortality and suffering, morbidity in India. Second leading cause of death in India. Please don't forget. Diagnosis of COPD, the symptoms, risk factors, and spirometry is extremely important. Management, you have to prevent. You can prevent COPD to a great extent. Non-pharmacological management, extremely important. And pharmacological management is also very important. So all of these are going to be addressed by the revised module that is Dr. Sunny would be releasing through my. Thank you. Thank you for the patient listening. Dr. Sunny, I exceeded by 2 minutes. Sorry for that.
No, sir. It's really very good insight of the knowledge about the COPD and the differentiation between the COPD and asthma. And of course, the participant could aware about that due to exposure only we can have the COPD. However, the asthma can be happen genetically. So it is really good for prevention not to spread the COPD, and people should be aware about the COPD. Moreover, the use of inhaler is also important, that the proper use. The drugs are very costly. We need to have some mechanisms to be there, and we need to have the training of our healthcare provider to spread the uniformity, how to use the inhaler. That is more important. That in this presentation, we could see that the importance of COPD and asthma, the second highest burden in the country, and of deaths, and the risk factors, the early signs and symptoms, which is really important. The most important thing is know your lung function. So I request all the participant in your area, spread the awareness on the know your lung function of the community, as well as your healthcare providers. So with this, I really thank you, sir, for insight of this COPD and chronic respiratory disease, including COPD and asthma. And I really thank all the participants who has joined this webinar, and I really thank the team Eco India for providing the platform for spreading awareness and this technical session. Thank you. So we'll close this session here, and
Thank you, Dr.
next. Thank you, sir. We will have next session on the next Thursday. Yeah. Thank you.
Thank you, sir.